Welcome to today's video. We're going to be discussing hypertension. That's the topic today. So what we'll start with is going to be the determinants of blood pressure. So blood pressure is equal to the cardiac output times the total peripheral resistance. And so cardiac output, that is the amount of blood that the heart is pumping out, and the total peripheral resistance is how much the vessels resist the flow of coming out. So cardiac output is broken down into two separate components. The first is going to be stroke volume, and stroke volume is going to be the amount of blood that's pumped per beat. And heart rate, which is how many times your heart beats per minute. So therefore, cardiac output is the amount of blood pumped by the heart every minute. Now, the total peripheral resistance is more determined by your vessels. And there's two components of your vessels which primarily determine this resistance. The first is going to be the radius of the vessel. So the larger the radius, the less resistance you have, and so then it's easier to pump blood out. And of course, vice versa, if the radius is smaller, then it's harder to pump the blood out against that increased resistance. The other thing that affects total peripheral resistance is compliance of the vessel. And another way to think of that is how well it can accommodate increase in blood flow. So the easier it's able to accommodate, then the less peripheral resistance you'll have. So what determines stroke volume? We'll just kind of go through each one. Stroke volume is determined by the intravascular volume, meaning how much blood and plasma and everything is inside the actual vessel. Now, the main ion which determines the intravascular volume is sodium. Sodium is the main determinant in your blood or plasma, and so the more sodium you have, the more intravascular volume you have, and of course the less sodium you have, the less your intravascular volume. And that makes sense that if you have a patient with high blood pressure, that he has a low sodium diet. However, what's interesting, only sodium with chloride causes increased intravascular pressure, not sodium alone. So this is interesting, and there's many ideas about this, but the current idea is that when you have chloride with sodium, it causes reabsorption in the kidneys, and so you're not able to excrete the sodium as you would if you had sodium alone. So that's the idea there. Heart rate is constantly adjusting depending on the demands of the body, whether metabolic needs or that is something your body constantly adjusts. Radius depends on constriction and dilation of the vessels. And it can also be determined by hypertrophy. So if the vessel, even though it's not constricting, but if the vessel wall gets thicker, either due to some type of compensatory reaction or atherosclerosis or anything like that, that can also lead to a decrease in the radius. And the decrease in radius can be determined by the alpha-1 sympathetic nervous system and the endocrine system. So various hormones that we'll get into later that can also cause vasoconstriction. And one important thing to keep in mind is radius is to the fourth power. So a small change in radius gets multiplied 4 times as far as with the total peripheral resistance. So radius is the biggest determining factor of what your resistance will be at any moment. Compliance, when we talk about compliance, we're talking about vessels that maybe tend to get stiffer. So if the vessels become stiffer, you increase the volume, it's not going to be able to accommodate that volume, so you're going to increase the resistance right away. And this tends to be a problem in the elderly. So elderly tend to have older, more stiffer vessels that aren't able to accommodate to changing blood volumes. Okay, so now that we've talked about kind of what makes up blood pressure, next thing we'll talk about is different ways your body controls blood pressure. So the one way is going to be with the autonomic nervous system, and this is going to be with increasing sympathetic flow. So when you increase sympathetic flow, you automatically increase the blood pressure. And this can be done by different receptors. So alpha-1 causes vasoconstriction. So that's the first receptor that it can be. And so that will affect the radius. Beta-1 is going to increase your heart rate. And so that's going to affect, so beta-1 here and alpha-1 there for radius. And alpha-2, it decreases sympathetic outflow, and so what it'll do is it'll inhibit beta-1 and it'll inhibit alpha-1, and so the inhibitory to both. So alpha-2 actually decreases sympathetic heart flow, and so then it's going to lower the blood pressure, and we'll see in some drugs that alpha 2 agonists take advantage of this point. Renin angiotensin aldosterone system. This is another major factor. So renin eventually leads to development of the angiotensin 2. There's some steps in the middle, but that's not really necessarily important at this moment. And angiotensin 2 increases the amount of aldosterone that's present. So this is your renin angiotensin aldosterone system. What activates renin? The first thing that can activate renin is going to be increased sodium chloride in the thick ascending loop, and this is at the loop of Henle in the macula densa area. Decreased pressure in the afferent arteriole of the glomerulus is another factor that can activate renin. And finally, beta 1. So beta 1 not only increases heart rate, but it can actually activate renin as well. So that's another thing to keep in mind. Angiotensin 2 tends to cause vasoconstriction, and so that affects the radius, as right there, so angiotensin 2, so we'll put that in the radius column. And finally, aldosterone increases sodium reabsorption, and eventually that's going to lead to an increase in intravascular volume. So we can write that over here, aldosterone, increasing stroke volume. Now, there's other aldosterone for a long time has other effects. The first is going to be it can cause nephrosclerosis. It can even, within the heart, it can lead to myocardial fibrosis. And even the vessels, it has some effect, mainly vascular inflammation. So that is the sympathetic and renal aldosterone. Now let's talk about the different hormones. Many different hormones have effect on the blood pressure, such as cortisol, epinephrine, thyroid. So many we could discuss. So that's just something to keep in mind. So we'll just write etc. instead of naming them all. Now let's take a look at complications. We kind of finished that subject up. So different complications that you'll have because of hypertension. The first organ it can affect is the heart. It can cause left ventricular hypertrophy, and this can lead to sudden death because oftentimes it's asymptomatic and the patient won't know until he's suddenly doing something, and then the heart gives way. It can also lead to congestive heart failure and sudden, like we mentioned, sudden death. We'll just write that again. So that is the effects on the heart. Stroke is another complication. Hypertension is the strongest risk factor for stroke, and so that's something you need to keep in mind. Now, what can it cause? 85% of the time, it causes just infarction. However, you can have some hemorrhages such as subarachnoid hemorrhage, and you can also have intracerebral hemorrhage. Besides this, there's a specific type of infarct called lacunar infarct, and this will tend to present as a cognitive decline. So all four of these different types of strokes are associated with elevated blood pressure chronically. It does affect the renal system. Now, this is going to be interesting because not only does it affect the renal system, but the renal system is the most common cause of secondary hypertension. So it kind of works both ways. It can lead to end-stage renal disease or even renal injury. And this is one where it's more common in black people, the renal injuries. And what's interesting about when the hypertension affects the renal system is it creates a vicious cycle. So when you get the hypertension initially, this leads to increased filtration, and so since you have increased filtration, it puts more work on it. You get hypertrophy, and eventually you get focal segmental glomerulosclerosis. Once you have that, this leads to nephron loss, and then the nephron loss itself is going to lead to hypertension. So and then the hypertension again will lead to the hypertrophy and focal segmental glomerulosclerosis. So it becomes a vicious circle, and you need to stop that hypertension to prevent this circle from just continuing on. The best marker is going to be albuminuria. This is the best marker to determine kidney function, in a hypertensive patient. Finally, it can affect the arteries. Primarily, it develops atherosclerosis, and generally these are asymptomatic. However, some patients may present with claudication, but again, that's very rare, and usually it's not significant claudication to bring it to medical attention. So that's the complications of hypertension. Let's now look at the definition. So we'll look at what the exact definition of hypertension is. Generally, if a patient is able to keep their blood pressure under 120/80, that's considered normal. And we're going to do this in millimeters of mercury. I'm just not going to write it over, I'm not going to write it over and over again. So just remember this is all in millimeters of mercury. Now, if they get above 120/139 or 80/89, then that is called prehypertension. Once they're above that, that becomes stage 1, and that's going to be anywhere from 140/159/90 So that becomes stage 1. And finally, you have stage 2, which is pretty much greater than 160 and over 100. So once you have that, that's going to be your final stage there. Now, depending on, sometimes you can have only systolic or diastolic affected. It's called isolated systolic if you have a blood pressure that's greater than 140, but the diastolic is less than 90. And then you have isolated diastolic, which is the exact opposite. So in this situation, your systolic is less than 140, but your diastolic is still greater than 90. So that's going to be your 2 there. Now, one blood pressure reading is not enough because blood pressure does fluctuate, minute by minute even, right? So you have to make sure, you have to take the average of 2 blood pressure readings, and they have to be in 2 separate visits. And this has to be, across 3 months. So that's when you can start diagnosing someone with hypertension. Now, what's even better is the use of what's called ambulatory blood pressure monitoring. So ambulatory blood pressure monitoring. So what this is a patient's going to wear some type of monitor for 24 hours, and that monitor will measure the blood pressure every 15 to 30 minutes. Now, this is beneficial because it can try to show you the nighttime dip. So what is the nighttime dip? Well, what happens is when you're sleeping, the blood pressure tends to decrease by 10 to 15%. Now, if this is attenuated, so if it doesn't decrease by that much, that suggests some type of cardiovascular risk. So that's a nice thing to try to figure out with ambulatory blood pressure monitoring. Also, it can take into account the white coat hypertension. And what white coat hypertension is when they are at the office, they might have high blood pressure, but when they're at home, they might have low blood pressure. So using this monitor, it can help differentiate with that. And then finally, you have masked hypertension, which is the exact opposite of white coat, where at the office they have low hypertension, and at home they have high hypertension. So it'll help diagnose that. Now, what are the different causes? Let's talk about etiology of hypertension. Most commonly, the etiology is essential hypertension, and that's about 80 to 95%. And pretty much what this means is 80-95%. So pretty much what this means is there's no cause. So we can't identify any underlying cause. It just seems to be essential. So you see, they used to think that the reason why it's called essential hypertension, they just thought that it was essential for some people to have this. But now they realize no, they shouldn't have that. They should have lower blood pressure. And so the name's kind of stuck. The other is going to be secondary causes. So this is going to be hypertension due to a identified factor. One of the major factors is they're taking some sort of drugs. So this can be OCP, NSAIDs, tricyclic antidepressants, even SSRIs, glucocorticoids, erythropoietin, if they're taking that, is another common cause, cyclosporin, and even decongestants. In particular, pseudoephedrine, which is a alpha-1 agonist. So these are the various drugs, and of course there's more. This is just a summary list. Renal causes, these can be tumors, cysts, and even renal artery stenosis, because that decreases blood flow to the afferent arteriole, and that can trigger renin. So continuing on, adrenal causes. So you can have increased aldosterone, which will increase intravascular volume. Cushing syndrome, cortisol. Pheochromocytoma, which releases epinephrine, and even 17-alpha hydroxylase deficiency will increase aldosterone as well. Endocrine causes, obviously hyperthyroidism is a very common cause. If you have that, that can definitely lead to hypertension, and high calcium levels. And just to kind of add a few more, aortic coarctation is one cause, and if the patient is pregnant, you could also take into consideration preeclampsia or development of eclampsia with seizures. So that's the basic etiologies. Now, when you do have a patient that's diagnosed with hypertension, what is going to be your evaluation? So maybe the first thing that you're going to want to do is kind of look at the various symptoms that might be involved. Primarily, these are asymptomatic. However, some people do complain of something what's called a hypertension headache. This tends to be in the occipital lobe and tends to be in the morning more commonly. They may also have dizziness, palpitations, fatigue, and even impotence. But these are very generalized symptoms and doesn't necessarily point specifically at hypertension. So overall, you can say it's asymptomatic. History is important. The first thing you want to ask is duration, how long they've had it, because that's really important. Diet and drugs, because of course if they have a high sodium diet or if they're taking a drug that might induce hypertension, you can just take them right off and they might become normal. So that's important to list at that. Family history is very important. You want to ask not only about hypertension but other cardiovascular disease. Also, if they have associated diabetes mellitus, if they're smokers, you should ask about how much they exercise, physical activity, and ask medical history as well. This could be, the most relevant is going to be a stroke or a transient ischemic attack, myocardial infarction or angina, and finally CHF. So, these are all kind of complications of hypertension that you do want to kind of figure out if they have it or not. Next, you're going to want to do a physical examination, physical. Okay, so let's just say physical evaluation. Okay, the first thing you want to do is figure out BMI because that's a very, very common risk factor. And then you're going to want to also check blood pressure. So you want to check it in both arms. That's important. You want to do it standing and sitting to rule out orthostatic hypotension. And you want to also try the ambulatory blood pressure monitoring, again, to kind of look at what we talked about earlier. The next important exam is a fundoscope. And so the reason why fundoscope is so important is because this is where you can directly visualize the arterioles, and that kind of gives you an idea of how the arterioles are throughout the whole body. So that's a very important examination to do with hypertensive patients. Bruits are important in the femoral, abdominal, and carotid. You want to check for bruits in that area because atherosclerosis can be very common and lead to that bruit. Thyroid, you want to check that in case they have hyperthyroidism. Murmurs, you might hear a loud S2 or an S4 gallops. These are kind of some things you want to look for. And besides this, you want to do a full cardiovascular and neurological examination to make sure that none of the complications that occurred earlier are occurring with the patient. What labs do you want to do? Of course, the kidney is affected, so you want to do urinalysis, you want to do albuminuria, and you also want to check the BUN and creatinine. Now, another thing you want to do is you want to try to take a look for metabolic syndrome. So metabolic syndrome is when the patient has hypertension, diabetes, and high cholesterol and high LDL and low HDL. So you want to make sure you check for fasting blood glucose. You want to check the cholesterol level and again the lipid levels. And this is important to. So once you diagnose metabolic syndrome, there's certain diets and exercise regimens they need to be on to help prevent future cardiovascular disease. And finally, you do want to take a look at electrolytes, such as sodium and potassium levels. That's the most important in case there's hyperaldosteronism, and you also want to check calcium because that's associated with hypertension as well. If they show signs of hyperthyroidism, you might want to do check TSH, but if they don't have any signs, it's not necessary to take a look. So now let's talk about treatments. Sorry about that. The first line in treatment is going to be, treatment here. First line treatment is lifestyle intervention. Now, this is effective in pre-hypertension, preventing it to become hypertension. But even if they do have hypertension, although it's not going to cure it, it does help decrease the dosage of the drug required. So it's still helpful to use this. Now, the first lifestyle intervention is going to be weight reduction. And what they found that for every 10 kilograms, you can decrease your systolic by 5 to 20 millimeters of mercury. And the ideal is to become a BMI of less than 25. So that's one step you can do. The second is just decreasing salt intake. And so the patient can decrease their sodium intake to less than 6 grams of sodium per day. That can decrease the systolic blood pressure by 2 to 8 milligrams of mercury. So that's another thing that can happen, that they can do. There's a specific diet which is called the DASH diet, which is known as the dietary approach to stop hypertension. Pretty much in this diet, they have a high fruit and vegetable diet with a low fat diet, and this can drop the BP 8 to 14 millimeters of mercury. So that's pretty significant right there. Physical activity is another great way to get the BP down. Even a brisk walk of about 30 minutes a day has been shown to decrease the BP by 4 to 9 millimeters of mercury. So let's write this down. So 4 to 5 millimeters of mercury. So this is your 4 type of lifestyle interventions. That doesn't work, or if they get into hypertension, you want to start pharmacological therapy. And this you actually want to initiate when the BP is greater than 140 over 90. Now, which drug to do? There's lots of choices to take into consideration. But what you want to do is take into consideration the race, the age, and the comorbidity. So depending what the race are, the age is, and if they have any comorbidities, one drug will be better than another. And so what you want to start off with initial treatment, you want to just start off with an initial monotherapy. So you only use one drug. And so the drugs you have to choose from is thiazides, calcium channel blockers, and ACE inhibitors, and aldosterone receptor blockers. So these are your 4 different choices. Now, the thiazides and calcium channel blockers work better on the African population, such as the blacks, and ACE inhibitors and angiotensin receptor blockers are better with patients with some sort of renal problem, and that includes diabetes mellitus and chronic kidney disease. So those 4 are the most common first step, and depending on the race and comorbidities, you might want to choose one over another. Other drugs such as beta blockers can also be used. So let's wait a second. So beta blockers here. You'd want to use beta blockers if the patient has a history of ischemic heart disease. That'd be a good time to use it, and heart failure. So there you go. Alpha blockers, alpha 1 specifically, if the patient has benign prostatic hyperplasia, definitely use that because it'll help not only the hypertension, but it'll help the prostate. Loop diuretics is definitely a good idea if there's congestive heart failure or edema. And if the patient is pregnant, alpha-methyl dopa and hydralazine are definitely a good option, as well as labetalol and nicardipine. So we have hydralazine and labetalol and nicardipine. You want to use that in situations where you have preeclampsia or eclampsia. So that's a great way to go. Now, if that doesn't work, and usually it doesn't, you're going to want to go into, so this is 1 and 2. Okay, you want to start then use combination therapy. And so the reason why we use combination therapy is because combination therapy, and by the way, the first drug doesn't usually work, so it's not enough. So that's why we need to add 2. And combination therapy is generally better than increasing the dosage of the drug, so that's why we tend to add. Now, good drugs to add is going to be either a long-acting ACE inhibitor or angiotensin receptor blocker, or you can add a calcium channel blocker such as dihydropyridine. Now, when thinking of combining drugs, you have to keep in mind that diuretics tend to accentuate the effects of ACE inhibitors, ARBs, and beta blockers, but they don't really tend to work too well or increase in effectiveness with calcium channel blockers. So keep that in mind. You generally don't want to mix diuretics with calcium channel blockers. And another good, when if you start with a diuretic, another good idea to do is give a potassium channel blocker or potassium sparing diuretic. And this is helpful because the diuretic is probably causing hyperkalemia. So by giving a potassium sparing diuretic like spironolactone, you're able to combat that and decrease the hypertension. Now, if this doesn't work, third drug could be a diuretic. You can maybe add a diuretic. That's generally used. So how much do you treat? What's your goal here? Because they're asymptomatic, so you have to have blood pressure goals. So generally, how would you start it? You generally, every 2 to 4 weeks, you increase the dosage until the blood pressure is under control. And once it's under control, you reevaluate every 3 to 6 months. And that's just to make sure that the blood pressure is maintained, and it's, you might want to add drugs or take away if it's too low or too high, depending on the situation. Now, if they're less than 60 years old, you want the blood pressure to be 140 over 90. And if they're greater than 80 years old, then you give a little more leeway. 150 over 90 is okay. Now, between those ages of 60 and 79, then it just depends on comorbidities. So what are some comorbidities? For example, if the patient has cardiovascular, renal, or diabetes mellitus, you need to treat these more aggressively. So maybe give a few more drugs and try to get the blood pressure strong under control. And if there's proteinuria, you actually want to get the blood pressure below 120. So it's important that you remember that fact, that proteinuria, blood pressure's got to be much, much lower. Now, if this doesn't work, this is called resistant hypertension. And the actual definition of resistant hypertension is blood pressure that's above 140/90, even with 3 drugs. So that's your definition. But you have to keep in mind there is pseudo-resistant hypertension, and this just means that the patient does have this, or there's other factors that's maintaining the patient's blood pressure. This could be white coat hypertension, which means just at the office. It could be due to non-compliance with the drugs that they're taking, or they may be taking some additional drugs, which is causing a constantly elevated blood pressure. So that's your general goals. Now, the final thing that we want to talk about is called a hypertensive emergency, also known as malignant hypertension. So when you get a patient who has a really, really high blood pressure, that's kind of what we're talking about here. But keep in mind that hypertensive emergency is defined by end organ damage, not how high the blood pressure is. So a patient who has really, really high blood pressure, but doesn't have, otherwise fine, doesn't exhibit any signs of, retinopathy, brain or kidneys, that's not malignant. That just means they just have really high blood pressure. But if they have malignant, then there's a very, that means you need to bring the blood pressure down much more quickly than if it's non-malignant. Another thing to keep in mind that the rate of increase of the blood pressure is more dangerous than the final level. And that's just because if it increases slowly, the body will accommodate it and kind of, change itself to accommodate the change in blood pressure. But if it raises really quickly, it can't accommodate quickly enough, and so then you end up getting end organ damage. So what are the organs we're really worried about? First is the eye. They do tend to get retinopathy, and so you want to look for, you want to do fundoscopy, you want to look for hemorrhage, you want to look for signs of exudate, and you want to look for papilledema. So that's the 3 signs you look for in there. When it comes to brain, you're looking for encephalopathy. So person with high blood pressure and they seem to have encephalopathy, that's when it's an hypertensive emergency. And finally, renal. So if the patient comes in with proteinuria, that is hypertensive emergency. However, you do want to rule out maybe they're taking MAO inhibitors or they're cocaine addicts. So that's 2 things you want to rule out before you start treatment. So how do you treat? You want to bring down the blood pressure quickly, but do not be overly aggressive, because the body has probably accommodated to the high blood pressure, and so sudden drop in blood pressure can lead to either cerebral ischemia. It can do a sudden decrease in blood flow to the kidneys and the coronary blood flow. So you don't want to do that. You can actually cause ischemia. So how much do you want to do? 25% decrease within minutes to 2 hours is what you generally want to do, or just try to keep around 160 over 100 to 110. So just kind of get into there. You can do there pretty quickly, but don't go below there much more quicker than that. The drugs you want to use is IV nitroprusside. This is good because it's a very short-acting vasodilator, and it has a rapid onset. And so vasodilator, and it has a rapid onset. And so this allows you minute-by-minute control of the blood pressure. And so this minute-to-minute control is helpful. Okay, because if you do drop it too low too quickly, then you can make an adjustment. And finally, you can also use labetalol and nicardipine. Those are commonly used as well. So